Thank you for having me. This is really a pleasure to be back at the, what I like to refer to as the British Society. The aortic guidelines that were just put together by, on the American side and the European side, have similarities and differences. And first of all, I wanted to talk about guidelines in general. If you listen to Blaise Carabello, he said, if you follow the guidelines perfectly to the letter without fail, you're not doing your job. Guidelines are not commandments. And so when I try to zero in on how to interpret a guideline, I think the first thing we have to do is assess the trustworthiness of the process. How was the guidelines put together? Was systemic review? Did they avoid conflict of interest? Did it include a panel of experts? And what was their methodology to achieve consensus? We need to understand the implications of the recommendations. Are they clear? Like we just heard, some of them may be a little bit unclear. Are they actionable? Can we do something based on those? And what's the strength of the recommendations? Thirdly, we need to evaluate the applicability of those guidelines to your practice. Is your subset of patients different than the patients they reviewed in the guidelines to come up with the recommendations? And are the recommendations up to date? Are they timely? Well, the Institute of Medicine in America came up with the clinical practice guidelines, sort of outline of how to perform the guidelines. And the question is, what did that include? Most of the guidelines then that had been written to that point and around that point did not really follow all those recommendations for what would make a guideline to be of high quality. Dr. Svensson, who's currently the president of the AATS, put together a document that described the AATS's approach and the STS as well later on, what the approach was to clinical practice guidelines. The idea behind the clinical practice guidelines are to reduce inappropriate clinical care from physicians who may not be familiar with a certain patient and need some guidance. They need to follow the IOM principles and develop specific algorithms for treatment. The expert consensus document, though, involves just an expert opinion group coming up with recommendations and clinical suggestions as opposed to guidelines. Methodologies for consensus. One of the recommended methodologies is the modified Delphi method. That's where there's an 80% response rate of everyone on the guidelines committee with 75% agreement or strongly agree with the recommendation. And you can have multiple rounds of voting with alterations of what the guideline would be. If there's not consensus, you can discuss it in the text, where the discussion was and debate was between the topics. The EACS-STS guidelines had 75% consensus threshold, which was met in almost all the cases ultimately. The ACC-AHA has historically only required a majority, 50%, in order to come up with a recommendation, which is why some of those recommendations you all remember hearing about the coronary guidelines a few years ago came about because the AHA-ACC committee had far more cardiologists than surgeons. So recommendations needed to be developed by an expert group. So I did a PubMed search and went through every single author in both of these groups of guidelines we're talking about today. And the EACS-STS guidelines had 26 co-authors. The number of average publications for those authors was 74, so quite significant authorship and history of writing about the aorta. 85% were over 30 publications, 92% were over 20, and only 4% had less than 10 publications. In contrast, the ACC-AHA group had a very diverse group of authors. The number of publications was far less, at a mean of 32, and there were 34% of the co-authors on that guideline that had less than 10 publications. So there were some non-experts on that panel, and that's one of the things that we need to take into account. And what are the durability of recommendations? Well, there was a group that reviewed 4 major guidelines in different specialties and evaluated persistent validity. 1 year, 92% of the recommendations were still valid, but by 3 and 4 years, less than 80% of the guidelines that were in those recommendations that were in those guidelines were still current and applicable. So they fade pretty quickly. So are they useful? There was a survey done of 206 cardiologists, and they found that 90% of them found the guidelines to be useful, and they used them in 80% of their patients when managing their approach. What about weak recommendations? Are those relevant at all? Well, 2/3 of the recommendations were found to be helpful even if they weren't class 1, and it was found that the clinicians did seek guidance even when the evidence was weak. So here again we can see where the level of evidence and the strength of the recommendation occurs that was used for these two studies. There was a study done looking at 19 of the ACC/AHA guidelines other than this aortic one. There was 3,271 recommendations. 50% were class 1. Only 11% of those class 1, however, were level of evidence A, which is the most strong level of evidence based on multiple randomized studies. And what the group determined or came up with was that there was an evidence gap, that we needed more clinical trials. So these are the two guidelines, the American guidelines on the left and the European guidelines on the right that we've been talking about. I went through all those recommendations. On the Americans, 283 recommendations. Half of those were class 1, but there was only 5 recommendations that were level of evidence A. Looking at the EACTS STS guidelines, there were 252 recommendations. 44% were class 1, similar, but they only had one level 1A recommendation. So what I want to delve in deeper then is, what are those 5 recommendations from the ACC/AHA guidelines, and are they truly what we would all consider here to be level 1A? Well, the first one is in patients with Marfan syndrome, treatment with either beta blocker or an ARB in maximally tolerated doses is recommended to reduce the rate of aortic dilatation. The European guidelines didn't address medical therapy. That wasn't their mission, I don't think. And so I think we will pass that one off as passing the 1A. There have been multiple beta blocker studies in Marfan patients and losartan and other ARBs looking at growth rates, and I think there's multiple randomized studies demonstrating that is in fact a positive benefit. So the second recommendation, using spinal cord protection during a thoracoabdominal aneurysm. In patients undergoing open TAA who are at high risk for SCI, cerebrospinal fluid drainage is recommended. The European guidelines are similar, even more widespread or more involving more patients. CSF drainage for spinal cord protection is recommended in open TAA. They didn't limit it to patients that were necessarily at high risk for SCI, but they gave it a 1B instead of a 1A. So let's look at some of the data to support that. Here was a study from Caselli in the early 2000s, where we looked at 145 patients that were randomized to drain versus no drain. They all had left heart bypass, permissive hypothermia, and intercostal reimplantation. They found that the operative mortality was 45% if they did have a paralysis event versus 5% without a deficit. So quite dramatic, and that demonstrates how important it is to avoid. And they found that the spinal drain use decreased the spinal cord ischemia significantly when compared to the control group. And that was most relevant in extent to aneurysms that extend from the arch down through the viscerals. So there was also 2 other studies that were done. Crawford had a randomized study. He did not say a significant difference, but he did not use all of those other methodologies that both Svensson and Caselli used to decrease hypoperfusion and other causes that can be attributed. And if you look at all these 3 randomized studies, the odds ratio is 0.49, and there's also been a meta-analysis as well. So I think, when you do look at spinal cord drainage, you have to look at the complications as well, and the complication rate is generally pretty low, less than 1% of actually having a neurologic complication from the spinal drain. So if you can decrease the risk by over 1%, then it's probably useful to apply the spinal drain. And we won't talk about delayed paraplegia. But again, looking at the guidelines, if you look at the European Guidelines Level A, data derived from multiple randomized clinical trials or meta-analysis. In this case, I think there were multiple randomized controlled trials that, when put together in a meta-analysis, also supported the use of a drain. So I think you could probably say this is a 1A. Whether or not you want to say it should be used in high-risk patients only or not is probably debatable. So the third recommendation, in patients undergoing open repair of TAA involving the renal arteries, cold blood or crystalloid is recommended to provide effective protection against renal injury. And the Europeans also suggest using visceral and renal perfusion in open TAAs, but again, 1B. So let's look at renal perfusion. This was 30 patients with an extent 2 TAA. You say 30 patients randomized. Well, I mean, this is not that common of an operation, so it takes a while to accrue 30 patients randomized. This is where the group used lactated ringers with mannitol and steroids intermittently and compared it to blood perfusion with passive hypothermia. One thing I want you to notice is that they used 400 milliliters a minute combined with the viscerals. So the renals and viscerals combined were going at 400 milliliters a minute, approximately. They used a renal dysfunction score using a serum creatinine rise of more than 50% within 10 days as a criteria. Maybe that's pretty soft criteria for renal dysfunction. That they did find more renal dysfunction with the blood than crystalloid group. But when you look at this and look at, for example, this bottom half of the table, score at discharge, there were 2 patients in the cold perfusion group that had a double rise in their creatinine level compared to 1 in the normothermic blood that had dialysis. So I'm not sure you could definitely say that one is better than the other, for sure. So then there was next a randomized controlled trial of cold blood versus cold crystalloid. This one involved 172 patients, a longer period of time. This one used cold blood, but it was used intermittently. And if you look at the number of the viscerals, again, they were giving the blood they were giving the viscerals 400 milliliters a minute, whereas remember, prior, they were giving the viscerals and the kidneys 400 milliliters a minute. So maybe they were under perfusing in the prior study. But again, using that soft criteria of increasing your creatinine by 50%, they did not find a significant difference. But also in the dialysis or elevated creatinine, they didn't find a significant difference. So those two were probably about the same. 2 other studies since then have looked at lactated ringers and compared it to custodial. These were from Milsano, and in those 2 studies, one was retrospective and one was prospective. They found using the rifle criteria for AKI, which is probably more relevant than the creatinine rise of only 50%. They did find that the custodial group had a significantly lower risk of any kind of AKI than did the standard crystalloid group. So I think in patients undergoing open repair of TA involving the renal arteries, some sort of perfusate should be used as opposed to none. But whether it needs to be cold blood or cold crystalloid, I think is not necessarily proven. I think that it certainly could be the passive hypothermic blood being recirculated, which is what I use. And I think that's probably good enough. I don't think that that original study was flowing at high enough levels. So I think it could be 1A that something is used. So I think that that's probably reasonable. 4th recommendation, what's the threshold for AAA repair? Well, the Americans said 5.5 in men and 5 in women. The Europeans were a bit softer on the change in women. This is the 1A recommendation, that men with 55 should be replaced, but women was softer at 2A even, C. And that was based on, if you look at the rupture risk, historically, this is from classic reviews, it's about somewhere between 5 and 6 centimeters is 3 to 15%. Now that didn't differentiate based on gender. What we do see on the table to the left at the bottom is that the female gender had a 1.5 odds ratio of rupture compared to men and operative risk. The 4 trials that randomized patients with small asymptomatic AAAs looked at patients with 4 to 5.4 centimeter aneurysms. 2 trials compared open repair to surveillance to EVAR to surveillance. There was an early survival benefit in the surveillance group, obviously, because they did not have to undergo surgery, but there was long-term no difference between the groups because of rupture in some of the non-operated patients. And if you look at men versus women, the women had a substantially higher hazard rate for rupture than did the men who were followed. And if you look at the variables associated with aneurysm rupture in this trial, you can see that the females had much higher rupture towards the latter portion of the follow-up, and actual female sex was the highest hazard ratio of any of the risk factors on the graph to the right, or the table to the right. And again, looking this time, though, at mortality, we have to keep in mind that the mortality for women is substantially higher for an open repair, about 1.5, and even higher than that difference between elective EVAR. So we have to balance out the risks. Now, if you look at the patients who ruptured, this is the women who ruptured that were below 5.5 in the follow-up study. If you move the target to 5, you will eliminate 9 out of those 12, so 75% of the women would not have a rupture, although they would have all had to have surgery. With a risk of 7.6 open, that might be sort of balancing it out, the risk and the benefits. So in patients with unruptured AAA, I don't know that you could say there's 1A that women should be replaced at 5, but I think probably at least 1C would be reasonable, because women probably should not be at the same criteria as men. So finally, what about open versus EVAR? The Americans say in patients with unruptured AAA, shared decision-making. That's it. There's no recommendations beyond that. Whereas the Europeans actually make a bit stronger recommendation based on life expectancy, recommending probably open AAA with long life expectancy, or with reasonable life expectancy, EVAR should be considered. And let's look at the data to support these 2 recommendations. On the left, you can see the survival between EVAR and open is quite similar. There might be some split towards open once you get past 13 to 14 years. Obviously, there's more reinterventions with endovascular. That's obviously predictable. If you look at here, focus on 0 to 6 months, second line, there's a near significant difference with a higher mortality in the open versus endovascular, but that's because the risk of the surgery is higher, but that they even back out and actually go a little bit the other direction towards favoring open repair once you get past 8 years. But these otherwise random studies done in a meta-analysis demonstrate no significant difference in long-term survival between the groups. Early survival obviously favors EVAR, but late survival probably is the same. So what about shared decision-making? Multiple position papers advocate for it strongly, and we all do shared decision-making in every patient we review, and we do it with empathy because that decreases buffers stress-mediated diseases, pain modulation. Really just, there was a study that 40 seconds of compassion could decrease anxiety and make the patient have all these enhanced benefits. But we also need to know what the surgery is going to do to the patient. I followed elective patients to see what their recovery was, and we found that they had a normal psychological recovery. After a thoracoabdominal aneurysm, though, their physical recovery was somewhat impaired compared to normal controls, and not every single patient got back to normal. The majority got back to normal by 6 months, but there was 10 to 15% of patients that never felt they were back at normal levels. So what do we recommend? I think pretty much you could decide to do an open repair or EVAR in any patient. If I needed one, I'd probably go with an EVAR, at least as the first option. So guidelines should follow guidelines. That's the first thing. The recommendations are predominantly level of evidence C. In regards to 1As, the guidelines are generally in agreement between the Europeans and Americans, and obviously shared decision-making can make an impact. So thank you very much.